Hi everybody, I am Dr. Pradeep Kumar Shanaisi, consultant rheumatologist, addressing you from Amrita Center for Rheumatic Diseases, which is located opposite to KMC Tower in Bangalore. In this video, we will look into two different aspects of systemic lupus erythematosus or SLE or lupus. They are lupus-like illness and latent lupus. In the first entity, that is lupus-like illness, patients will have clinical features suggestive of SLE, but they will not fulfill the criteria for systemic lupus erythematosus. That is American College of Rheumatology criteria or ACR criteria. While doing the blood test, they will invariably have ANA positivity in low titers, and the pattern will be of non-specific antibodies like anti-Rho or anti-CNPB. Their C4 level will be normal. Henceforth, this entity can be also called as undifferentiated connective tissue disease. Next entity is latent lupus. In this entity, patients will have non-specific symptoms that will not be pathognomonic of SLE. For example, patients will have arthralgia, myalgia and fatigue. In the laboratory evaluation, they will have again low titers of ANA positivity, again non-specific pattern like anti-Rho or CNPB, but their C4 level will be low. So this is absolutely latent lupus. Some textbooks mention that these two entities are one and same, but a rheumatologist will realize in clinical practice that these two are distinct entities. This shows that at a given point of time, a patient may not fulfill the ACR criteria for SLE. They might sequentially fulfill the criteria for SLE. So it is most important to keep the patient under follow-up. Coming to the clinical examination, delicate points about SLE. While examining the fundus, one can find cytoid bodies in the fundus, but this is not pathognomonic of lupus. Coming to the oral ulcers, they are painless ulcers found in the soft palate. So one should not ask the patient whether there is history of oral ulcers. ACR says that oral ulcers are typically noted by the physician, not reported by the patient. Mala rash of SLE, which is typically taught to undergraduates, they are definitely photosensitive, but they spare the nasolabial fold. If they involve the nasolabial fold, one has to think about SLE and dermatomyositis overlap or dermatomyositis in isolation. When one examines the dorsal aspect of the hand in a patient with SLE, the vasculitic rashes should be typically present in between the knuckles, that is in between the interphalangeal joints. If they are present on the knuckles, the patient might be having dermatomyositis again. Dermatomyositis and SLE are differential diagnosis. Coming to the arthritis of SLE, they are typically non-erosive, and the deformities which are found in lupus are corrective deformities. They are not because of the problems with the joint, they are because of the loose joint capsules, ligaments, etc. and they are correctable deformities. So it is called as Jacquard's arthropathy. Coming to pregnancy and lupus, most important question is why lupus flares in pregnancy. That is because in pregnancy there are lots of hormonal changes. That is, the levels of estrogen, progesterone and prolactin, they keep changing. This is to tolerate the fetus. As far as the mother is concerned, the fetus is a foreign body, so the mother has to tolerate it. So the Th2 response has to increase. The changes in the hormone increases the Th1 or Th2 response. So in pregnancy, to tolerate the fetus, Th2 response increases. Only then the mother can tolerate the fetus. Again, lupus is a Th2 predominant response. So that's why when the mother gets pregnant, if she is having lupus, to tolerate the pregnancy, when the Th2 response becomes predominant, since the lupus as well is a Th2 predominant response, lupus flares up. So Robert Lahita says, he has said in Delhi as well as in his book, that however stable the boat may be, the pregnancy rocks the boat. So the patient has to be in remission SLE has to be in remission for at least 6 months before conception, and on azathioprine, hydroxychloroquine, high dose to low dose to moderate dose of steroids, she should conceive. So SLE and pregnancy is very interesting. It's a different big chapter altogether, which we will discuss if there is any further questions over the phone in the next video. Thank you one and all.